Now I invite Dr. Rajesh Sinha. He'll be delivering his talk on nucleus management in presence of corneal opacity.
Thank you, sir, for this opportunity. A very good morning to all of you. I'll be talking about nucleus management in eyes with corneal opacity. See, the idea of the basic reason for presenting this topic is to understand, to discuss methods to enhance visualization, because in a case of a corneal haze or opacity, the visualization is an issue. So what is most important? It should be a well-dilated pupil, because if you have a central opacity and the pupil is not well-dilated, most of it will be covered by the opacity. If it's not dilating well, use hooks or rings to enlarge the pupil. Do it under peribulbar block, because many a times you handle the iris and the patient can have pain, and you can do it only if the opacity is partly covering the cornea. Trap and blue has been used for last almost, when I remember if it was in 97, 98 when it started, and for white cataracts to do the rexis it is used. But if you have a corneal haze or opacity, use it for a longer period. Why? Because it not only helps in doing the rexis, but it also helps you to see the capsular axis edge when you are chopping the nucleus, because of the corneal haze, it is difficult. Again, when you are doing a rexis, in such a case, when you are behind the opacity, don't leave the capsular flap. You leave the flap only in the area where the cornea is clear, so that you can hold it again and do the rexis completely nicely. And use of viscoelastic is very essential at every stage. You can do the chopping technique and keep your choppers, etc., in the area underneath the clear cornea, so that you can go ahead and complete the procedure. Once again, as you can see here, the capsular axis margin is still stained, so we can actually see the margin when we are chopping the nucleus. As I said, OVD inside the anterior chamber as well as over the cornea is very useful, because when you put a dispersive viscoelastic like methyl cellulose over the cornea, there is a sudden increase in visibility. And whenever you are doing a crucial step like chopping a nucleus, etc., in such a case, if you put a blob of viscoelastic like methyl cellulose on the cornea, it suddenly improves the visualization, and then you can go ahead and chop the nucleus nicely. As I said, good quality viscoelastic is very important. If you have a very hard cataract like this and you have a corneal opacity, if you have a corneal opacity, in such a case, if you keep doing the surgery, then it will be difficult to chop. So in such cases, even if the pupil is, say, 5 millimeters, wherein you can do the cataract surgery normally, easily, as Dr. Mishra was telling, it's better to enlarge the pupil in these cases, so that you can see the area beyond the opacity. So use iris hooks or rings to enlarge the pupil. We have also done a study on a slightly eccentric crater, so that if the opacity is on one side partly covering the pupil, you can do a crater, create a crater on the other side, slightly eccentric. Can't go too periphery, because there you have the epinucleus. Another important thing which is very useful is the use of endoilluminator, which improves the visualization in corneal opacities and haze. So when you are doing nuclear chopping, in such a case, you can ask your assistant to hold the endoilluminator from outside, so that you can do the chopping very nicely. And once you have completed the chopping, when you have to remove the epinuclear plate, it is better to take the endoilluminator inside and see it carefully. So you take the as you can see now, the endoilluminator is inside. You can exactly see the margin of the epinuclear plate. You can hold it and you can bring it towards the center and aspirate it completely nicely. And so that's how endoilluminator, again, is a very useful tool. Only thing is that we have to understand how best we can use it. Chandelier illumination, again, is a useful tool in cases not in a leukomatous opacity, but in cases wherein you have a haze, a very bad ocular surface, or where there's a haze. You put chandelier illumination, you can get a red glow. Go ahead, do a rexis, do nucleus chopping, etc., and complete the procedure. If you have a very bad opacity, in such a case, you can combine anterior laminar keratoplasty along with the nucleus management. So if you, as you remove the superficial haze, you can see, as you remove the superficial haze, you can see the cornea clears up. And now you can do any technique, whatever technique you want, go ahead, do a surgery, and then you can put corneal tissue depending upon the thickness of tissue that you have removed. If it is less than 200 microns, it can be left sutureless with glue at the edges, and if it's more than 200 microns, you have to put sutures. Something like this, a very bad one-eyed patient, another eye icicle. You don't want to do a triple procedure. In such a case, intraoperative OCT is giving you the idea that 80% of thickness is having the opacity. So in such a case, you dissect up to 80%, make it clear, leave a little bit of stroma, because if there is no stroma and a bare desmace, in such a case, doing a cataract surgery is very difficult. It can rupture the desmace. So go ahead and remove almost 90% of the opacity, and once you have done that, you can go ahead and complete the rhexis and the nuclear emulsification completely, and then of course you can put corneal tissue. So in conclusion, if we have an opacity or a haze in the cornea, the basic idea is to enhance visualization in order to do a cataract surgery. Trap and blue dye, use of dispersive viscoelastic on the surface. As I said, trap and blue dye for a longer period. OVD on the surface, endo illuminator, chandelier illumination, all these things are very useful tool in making life easier for the phacosurgeon. Thank you very much.
Thank you, Dr. Rajesh Sinha, for really nicely elaborating all types of corneal opacity and the nucleus.